Next, I would like to invite Dr. Rushad, who will be speaking on customized lasers for the normal and complex corneas.
Thank you, Ritika, and I'd like to thank Pooja for inviting me for this instruction course. I think the slides are. Okay. So I'm going to be talking on customized lasers for normal and complex corneas. Now, when we look at the various different profiles, there's the wavefront guided, the wavefront optimized, and of course, of late, there's been a lot of noise about topo guided treatments. So, looking at wavefront optimized and wavefront guided predominantly tries to treat the higher order aberrations, whereas wavefront optimized tries to maintain the asphericity, the aberrations, and the prolateness of the cornea. Now, topo-guided treatments are based on an ablation profile that is a customized ablation profile that regularizes the corneal surface. Uh, the initial thought was that the advantage of topo-guided treatments is in highly aberrated or irregular corneas, corneas with media opacities or corneal scars, and those were the ones where we were actually focusing on topo-guided treatment. With this in mind, I've divided this talk into customized lasers for both aberrated corneas, and we'll go through an example on how to treat those corneas, specifically keratoconic eyes, and normal corneas, and how this actually evolved into a primary treatment for virgin eyes. So this is a typical patient with keratoconus. You can see that there is elevation on the anterior posterior, and the keratometry is abnormal. So keratoconus management was initially about using C3R and then giving spectacles or contact lenses for rehabilitation. However, one very important aspect to pay attention to is the contact lens tolerance of these patients, and that's the most important question to ask them preoperatively. If a patient has uh, intolerance to contact lenses and you have enough corneal thickness, then it is worth looking at either Intax rings or topo-guided PRK to match it with your cross-linking to actually treat the refractive component of the condition as well to improve the outcomes. So initially there were the various different protocols. This is the Cretan protocol, which Dr. Kaimonis and group published, which was about the application of customized topo-guided surface ablation to treat keratoconic eyes. The disadvantage was that the ablation would thin out the cornea further, and therefore you were actually removing tissue which would get cross-linked with the C3R. So these are the various different protocols in literature which have been defined. The Bharat protocol by Dr. Rajat Jain is one which is indigenously developed in India on the NIDEC machine. And these are various different protocols and different machines. So topo-guided treatment can be done with pretty much any refractive platform these days. I'll just go through the planning of how to do it on the Wavelight, the Excimer from Alcon. That's the machine that we use. This is a patient, 26-year-old IT professional with ghosting and shadowing. He had a good corneal thickness. His corneal thickness was above 500. And his refractive error in the right eye, which is the eye that I've shown over here, was a +1 diopter sphere with a -5 cylinder at 60 degrees. His best corrected vision was 612 with this. And he was not interested in wearing contact lenses. So we selected the topo-guided treatment on the Wavelight platform. What we have to remember is that the topolyzer is a placido-based device, and you have to take multiple scans. Now, the issue in keratoconic eyes is sometimes the quality of the scans is not good, so you have to do at least 8 to 9 scans and select the ones with the best quality. The ablation profile, if you've noticed, is kind of mirroring what is there in the topography. So there'll be an ablation over the area of the cone and an ablation in the periphery for a hyperopic correction, as you can see over here. This is just to regularize the cornea. You can see that I've set the sphere, the cylinder, and the axis all at 0. This is, in fact, it's burning 43 microns of tissue just to regularize the cornea. There's no refractive treatment in this particular thing. Now you start from this point and then you gradually go up with your cylindrical correction to actually achieve a better refractive outcome in these patients. So you can see here, this is what it's actually treating when there is no refractive correction. As you go up, so you can go to about 1.75, you see that it's 44 microns, maximum ablation with a central of 29 microns. You go up to 2, it's increasing to 30 and 45. You go up to 2.25, which is showing 31 and 46, and then about 2.5. And I would not normally cross the threshold of 50 microns of treatment, even in an eye which has 500 microns of corneal tissue. And this is what we actually selected. We were debulking the corneal cylinder, and the axis that I put in, because the subjective and the calculated were roughly matching within 15 degrees, we went with the subjective axis. If there's a very large variation, then I would go with the the topography axis for the treatment. The optical zone you can set at 6 or 5.5, but again you have to be aware that you are basically not ablating too much tissue, and the transition zone should not be very little. You should try to max out the transition zone, otherwise you get a zone of haze because of the hyperopic correction in the periphery of the cornea. And this is what we actually went ahead with. And you can see that the post-operative best corrected visual acuity was 6.6 with a minus 2.5 diopter cylinder. And you can very nicely see in the comparison map that the central cornea, which is what we are concerned with, has become a more regular astigmatism, and effectively the cone has been moved out of the center of the cornea, showing a good outcome in this particular patient. Now, there are patients with 450 micron corneas where you can't actually do an ablative procedure, and we cannot plan a TPRK in these eyes. So there was another paper which was published by the NN group by Dr. Rohit and all, which looked at using the Schwind machine, which Dr. Nishant spoke about, to do a customized PTK in the area of the cone. So what you do in this, which is the Trek procedure, is you localize the cone on the tangential map, you measure the long and the short axis, and you perform a customized PTK over that area of the thinnest pachymetry, and you add about 20 to 25 microns of stromal ablation. So you're minimizing the ablation. Then you do a manual removal of the epithelium around it and followed by a cross-linking. And this was found to be effective in those corneas where you can't actually do a full topography guided correction with the PRK, but then you can do this to improve the visual outcomes. Now coming to normal corneas, what we realized was that most aberrations arise from the anterior corneal surface, and therefore this idea was born to use primary topoguided treatment, the Contura vision, for myopic correction. Now the burning question was, is this as safe and effective as we were getting good results with wavefront optimized treatment, so was this as good as that? Now the advantage of topo-guided treatment is that it's not limited by the size of the pupil. The correction of errors produced by more peripheral aberrations can be treated in this. It's not subject to error produced by corneal, lenticular or vitreous opacities, and it's not affected by the state of accommodation of the eye. This is what basically the TCAT does. It detects Myers, it calculates elevation data, it takes the various images, selects a median image, and the best fit A-sphere is subtracted, and it uses peripheral energy compensation for the treatment. Now, in our practice, what we started using is the Faucet's software. This is from Dr. Mark Lobinoff and group. This is actually a very convenient software engine to plan your topo-guided treatments. And this is what, there's a license that you have to download from after talking to Dr. Mark, and it actually makes topo-guided planning a lot easier. So this is an example. Again, you can see the topography over here with about a 1.4 diopter cylinder. The quality of the scans was pretty good, as we can see here. That's from the topalizer that's imported. And you can have a look here at these three elevated areas. This is again just with zero ablation. This is what treatment is being done to regularize the cornea. So there is a certain amount of treatment being taken to just regularize the cornea in this. Now this data is taken along with doing a subjective refraction, and then it's exported to the Faucet's software. This is what the screen looks like. You can customize it to your own profile. These are these elevation points that you can see here highlighted in the white circles. These are called taluses. So this uses something where it localizes these taluses, and what it's trying to do is actually calculate vectors both in terms of magnitude and direction. What we have to understand is that topographic cylinder is sometimes higher than the manifest cylinder that the patient accepts. So you have to do a treatment of the topographic cylinder, but you have to make a compensation in the spherical correction so that you are not treating an excess amount of MRSE. Your MRSE or your refractive spherical equivalent has to be maintained. So the machine maps out these various different taluses, and then it gives you these vector plots. So what it's showing you is that the clinical refraction, which is the manifest, is 5.5 with a minus 1.25 cylinder. What was measured in the topalizer was 1.31, and it's recommending a 5.44 spherical with a 1.16 cylindrical correction at 172. That's what it's doing. It also takes into account what is coming from the lenticular component by subtracting the manifest refraction from the topographic refraction. And this is the final planning that we did for this patient and fed it into the machine. We also had done a study when I was at NN regarding wavefront optimized versus topo-guided. We did a contralateral eye study, and these were the results from that particular study where we looked at refractive outcomes. We found that they were fairly similar. The sphere, cylindrical, MRSC corrected and uncorrected visual acuities were not statistically significant between the two groups. Along with that, we looked at the Q values. The Q values did show a slightly better Q value in the topo-guided group, again not statistically significant though. The aberration profile was also similar, but there were a few improvements in the topo-guided treatment where the spherical aberration was less induced. The total high order aberrations were less induced by the topography guided treatment. So that was where it scored over wavefront optimized in these virgin eyes. So what was known was that TCAT is a preferred treatment for aberrated corneas or decentered ablations, but what we managed to see going forward, looking at all these different studies, is that it can be used as a primary treatment modality for refractive surgery, and it maintains the asphericity and induces less aberrations than conventional treatment. So wavefront optimized and topo-guided treatments effectively correct low-order aberrations. Both procedures maintain asphericities of the cornea. Topo-guided treatment induces less aberrations, and the 4City software is actually a very convenient tool for planning topo-guided ablations. Thank you.
So, very nice presentation, Dr. Rushad. I wanted to ask you, I mean, we often get patients who had, say, slightly decentered ablations with reasonably good visual acuity but suboptimal vision. So would you ever consider a topo-guided treatment in them? What would be your selection?
You can, but again, so I've seen a couple of these patients. You have to see how much ablation, again, it's taking to do that treatment. Now, you have these various different platforms like the Schwind and the Wavelight. The Wavelight doesn't give you the ability to actually remove certain aberrations. What happens then is, I've dealt with a patient like this recently, the ablation just to do a regularization was inducing a myopia of about 2, and you were ablating about 80 microns. And his pre-correction was already 6 diopters, so it didn't make sense to do that. In those kind of patients, the Schwind does score over because you can remove a certain amount of coma and go into tissue saving mode and then do a treatment which would help and not induce as much myopia. But what we have to understand is in regularizing, sometimes you're going to create a myopic shift itself. So that is a consideration when doing these.
Okay. And for keratoconus, do you see topo-guided PRK working well, better in, say, decentered cones versus centered cones? Do you see a difference there?
So it doesn't work in every patient, but I wouldn't say it's 100% dependent on decentered or centered cones. Again, there are a lot of patients who have very good topographic outcomes, but then sometimes the visual recovery is suboptimal in these. I would say I think we've done about 15 eyes. 10 of them are doing reasonably well, 5 of them are not, and it's not like we had very specific results where centered cones were better than decentered, and it was a similar profile. So I think the recovery post keratoconus is dependent on multiple factors which we probably don't have a complete hang on yet.
Perfect. Thank you.
Are you doing any intacs for the keratoconus
I've
patients?
pretty much given up on Intacs. I don't do it very much because I feel that contact lens fitting after Intacs becomes more difficult.
Because
So
if you remember, we used to do Intacs and then centerizing the cone and then
Yeah.
doing a centered PTK on them. So do you think that was a better option to do instead of
So my whole problem with Intacs is the variability of the results.
results?
Again, it's much more variable than topo-guided treatment. So I prefer to then just do a cross-linking and then fit a contact lens if we can.
So I think the only valid indication for Intacs currently is post-LASIK.
It
Post
is,
LASIK
yeah,
it
that
is,
inferior.
inferior or a very
yeah,
decentered
yeah.
thing. Thank you.